Hello. In this part of Advancing Bronchiectasis Awareness and Education video series, I'd like to address the management of bronchiectasis. First and foremost, I want to emphasize that bronchiectasis is manageable, that effective treatments are present. The caveat to this, of course, is that no two patients are the same. What works for one patient may not work for another patient. An approach to a therapeutic plan needs to be individualized. This is all grounded in the triad of education, advocacy, and empowerment if we're going to have successful management. The best bronchiectasis treatment is the treatment that works for a patient and is used by that patient. And so we have to be mindful of this. When we think about treatment of bronchiectasis, we have to keep in mind the historical paradigm of the vicious cycle, and that is a cycling of infection and inflammation that leads to progressive airway damage and dilatation in bronchiectasis. This opens up the opportunities and understanding for potential therapies to interact. It is also important to realize that there's a wide section of etiologies. When we look at the distribution globally, the patients with bronchiectasis in North America or Europe may differ than in Africa, Asia, South America, or Australia, and we have to take this into account depending on where we're practicing. By doing that, we can then optimize the best approach to the therapeutic plan, understanding that in each region, oftentimes there are differences in availabilities as well as approach to practice. Let's turn our attention to that historical paradigm of the vicious cycle, that is, of the recurrent infections leading to worsening airway inflammation, tissue damage, poor mucus clearance, and recurrent infections. At each one of those components of that historical model of vicious cycle, we have an opportunity to potentially intervene. First and foremost, let's address airway clearance, which we think is the cornerstone for approach to bronchiectasis. We have to understand that part of the root of bronchiectasis is a permanent dilation of the bronchial tubes, impaired ciliary function, and retention of mucus secretions. So this is important to understand that this is an airway problem with retention of secretions and poor mucociliary clearance rather than an alveolar or interstitial process. If we're effective in preventing that retention or pooling of mucus or secretions within the airway, we feel that this is likely to minimize the recurrence of an infection. So airway clearance becomes an integral part of any therapeutic plan. There are lots of different sites to help us with this, and that to tap into some of these resources for airway clearance, as was maybe seen on the Bronchiectasis and NTM 360 site, is helpful. Let's do a little deeper dive into airway clearance, which again is the cornerstone of successful management of bronchiectasis. I generally will start out and encourage every patient to maintain some regular aerobic activity. This has great benefit from a pulmonary standpoint and mucus clearance standpoint, as well as substantial wellness effects for both women and men. Many patients will walk, some will ride a bike, do indoor other types of aerobic activities, or even yoga or Tai Chi. In any case, regular aerobic activity is essential for patients' wellness, including lung health. Other options become more optional in the sense that they're oftentimes tried, and the best options are the ones that patients are able to do, that are effective, and the patient will continue with. Those include deep breathing and active cycle breathing, postural drainage, use of a positive expiratory pressure valve, PEP valve, hypertonic saline by nebulization, or high-frequency chest wall oscillation. Active cycle breathing techniques are something that patients can work with respiratory therapists to facilitate clearance of mucus, airway clearance with positive expiratory pressure devices such as PEP valves, and there are a variety of flutter valve, flute valve, Arabica valve, acapella valve, and other products on the market that may or may not be available depending on what part of the world we're in. Postural drainage has been around for a long period of time and can be very effective in some patients with or without chest percussion. If there's a partner or assistant that can help patients with positional therapy, again, best coordinated by a physiotherapist. Nebulized hypertonic saline by either 3% or 7% concentration once or twice a day can be very effective. This is considered standard of therapy for cystic fibrosis patients, and for our adults with non-cystic fibrosis bronchiectasis can also be very effective therapy, and again, best coordinated by a chest physiotherapist. In select instances, even in our older patients, high-frequency chest wall oscillation may also help facilitate mucus clearance and improve symptoms. Sometimes, despite adjustments in the best use, this may or may not be tolerated, and it speaks to this concept that the best therapy for patients is the one they're able to tolerate and they continue to use. The next aspect of this vicious cycle is what to do about the chronic bacterial infections and what's the role of antibiotics. The European Bronchiectasis Guidelines in 2017 gave us some guidance in this direction. For those patients that have frequent exacerbations defined as 3 or more per year, use of a long-term antibiotic is an option. An inhaled antibiotic was recommended for those with Pseudomonas infection, and those with non-Pseudomonas infections oftentimes will receive long-term macrolide therapies. And in select instances, there may be even a combination of both inhaled antibiotic as well as macrolide antibiotics. This long-term oral antibiotic also then carries over into the component of an inflammatory process. Specifically, I do want to mention that corticosteroids are generally not recommended for bronchiectasis. On the other hand, if there is an underlying diagnosis of asthma or other steroid-responsive lung disease, it's important that steroids are not withheld. Macrolides become a different story, and there are 3 associated large trials that have had positive impact on outcome with bronchiectasis, and oftentimes are used on a more long-term basis. If there is consideration for using macrolide for a frequent exacerbator, it's imperative that non-tuberculous mycobacteria, NTM, such as Mycobacterium avium complex and other mycobacteria, are excluded prior to starting these antibiotics. And this is done primarily to avoid developing acquired resistance of the NTM to macrolide, which is a problem in itself. We don't want to make a problem worse. This usually involves collecting multiple sputum prior to consideration of using a macrolide, and then surveillance monitoring for sputum pathogens throughout the period of macrolide use. This then brings us to the component of using bronchodilators, and in very select instances, surgery. Bronchodilators may or may not be helpful, especially those in reversible airway disease. And surgery is also at times very effective for those individuals that have localized bronchiectasis that have recurrent symptoms refractory to treatment. I might add that surgery for bronchiectasis is most often done by those with considerable experience, and that this is a complicated procedure, oftentimes associated with increased morbidity in the hands of those with less experience. I can't help but not also address other general wellness issues which are crucial to effective therapeutic plans. This includes nutrition and at times consultation with nutritional services, regular exercise as part of the activity program, which may or may not involve a formal pulmonary rehabilitation program, avoidance of all tobacco products, including vaping, updates of vaccination, and to continue with an open conversation and dialogue with providers and physicians.